far you have come on your own, but never alone. Through the rain and through the shine, here's your moment, it's your time. You stood tall and now you see, standing in your destiny. 100 women growing strong. 100 women where you belong. You stood tall and now you see, you have reached your destiny. Woman, woman.
As people of African descent, we offer this land recognition in solidarity with the indigenous peoples of Turtle Island in the efforts and deliberate intentions toward decolonization. As people of African descent, we acknowledge the land of Turtle Island that sustains us, express deep gratitude to its indigenous peoples, and pledge to honor our dignity and divinity that ultimately connects us all. By Kay Johnson. Welcome to 100 ABC Fireside Chats. 100 Accomplished Black Canadian Women is a bold project initiated by co-authors and co-founders, the Honorable Dr. Jean Augustine, Dr. Denise O'Neill Green, and Donna Jones Simmons. Our mission is to celebrate and archive the professional accomplishments of trailblazing Black women from all across Canada. The goal is to create an ever-expanding database available for current and future generations via print media, public and private libraries, as well as our website, which is www.100abcwomen.ca. In addition to our fireside chats on topics that matter to our communities, such as education, healthcare, entertainment, creative arts, trade union, and so much more, we offer biennial book launching galas and biannual symposiums. The co-authors and co-founders would like to take this opportunity to thank each of you for attending today's fireside chat. We know that you will find these sessions educational and inspirational. So sit back, relax, and hear from our brilliant and talented honorees.
Good afternoon, everybody, and welcome. Thank you for joining us on Mother's Day for this important conversation on health equity, reproductive justice, and beyond. My name is Althea Jones, and I'll be moderating today's discussion. I'm a registered midwife, founder, and executive director of Ancestral Hands Midwives, Canada's first Black-led, Black-serving midwifery program. Today, we're here to explore a critical shift from thinking about reproductive health as simply access to services to understanding it through the broader framework of reproductive justice. This lens pushes us to consider not just whether care exists, but whether people have the power, autonomy, and conditions necessary to make decisions about their bodies, families, and futures. Today's discussion will also take us beyond healthcare systems alone and into policy, lived experience, labor, research, and community-led solutions. and I'm honored to be joined by an incredible panel of leaders whose work spanned research, policy, clinical care, and global advocacy. So today we're joined by Dr. Karine Cohen-Sanchez, a scholar and advisor specializing in governance, institutional accountability, and equity-focused policy, with a focus on how systems shape real-world outcomes. We also have Stacia Stewart, Director of Research, Policy, and Communications at Social Planning Toronto, with over 30 years of leadership advancing maternal health, reproductive justice, and community-based care. We have Marie Clark Walker, an international labor and human rights leader who has spent decades advancing equity and dignity for workers, including advocacy at the global level. And we also have Dr. Cindy Maxwell, maternal fetal medicine specialist and senior health system leader at Women's College Hospital, advancing Black reproductive health, research, and system transformation. Thank you all for being here. I'm very excited to be on this incredible panel with you. And thanks for joining us on your Mother's Day. So, whether you are a mother yourself, a mother figure, you have a mother, I want to just say thank you for being here today and for everybody watching. And so to ground us in our conversation, I'd like to start with you, Marie, with talking about how do you define reproductive justice and why is it's broader than access to reproductive health services alone?
Thank you for the question, Alfie, and happy Mother's Day and Mothering Day to my fellow panelists. So reproductive justice is definitely about more than access to reproductive health services. It's the fundamental human right to have children, not to have children, and to raise your families in a safe, healthy, and sustainable, dignified community. Developed and advanced, as you well know, Althea, by Black women, activists, and scholars, the reproductive justice framework recognizes that our reproductive lives are shaped not only by individual choices, but by social, economical, and political conditions which we live in. For Black women, reproductive justice means confronting the systemic inequities that we face every day and that continue to shape our health outcomes, whether it's anti-Black racism in healthcare, poverty, precarious work, inadequate housing, environmental racism, gender-based violence, and the lack of culturally responsive and culturally sensitive maternal care. It means to me that recognizing access to a clinic or service alone is not enough if women are still navigating discrimination, unsafe conditions, barriers that undermine our health and well-being on a daily basis. It's therefore inseparable from racial justice. You can't talk about reproductive justice without talking about racial justice, economic justice, labor rights, disability justice, and gender justice. And so it can't be achieved by focusing only on the individual access to care. We have to address all the systems and structures that produce the inequity in the first place. And that's why, for me, the role of Black midwives, doulas, and culturally grounded community care is extremely critical because we already know that Black women face disproportionately high rates of maternal mortality and poor maternal health outcomes. And because we know that midwives and doulas often provide that culturally affirming, trauma-informed support that improves our health outcomes, it's very, very important that that is part of our reproductive care and reproductive justice. It means that we have somebody that we trust, right? When we have those folks working with us. So reproductive justice calls on us not just to improve the services, but to transform the conditions that make Black women disproportionately vulnerable in the first place.
Thank you so much for getting us started with that definition. And I see lots of head nods. So before I open it up to everybody else, can I ask, how has your work in labor and global advocacy kind of shaped that understanding that you just gave us?
Well, no matter which country that you talk about, the one thing that we continue to hear is mortality within amongst Black women, whether it is, and they like to talk about countries like Canada, US, UK, et cetera, being much more advanced. but the mortality rates for us are just as bad. And so one of the things that we look at in labor is talking about how does precarious work, figure in more maternal health? How does having proper health services with people who are caring, with people who are not working precarious, nurses, doctors, doulas, midwives, who are not working in precarious situation, how does that help the situation of women who are looking for reproductive justice? So as I indicated earlier, all of it is connected. All of it is connected. And if you know that there is something that is working in a country, and when we're talking about midwives and doulas, we're looking at our history on the African continent, right? When you're looking at what works in those areas, in those parts of the world, we can be putting that here as well, instead of being, I want to use the word arrogant, in thinking that the systems that we have here work better. So part of my work is to be bridging that gap and showing people that what is done in countries that we look at as developing countries, third world countries, are not necessarily bad, worse. In a lot of cases, we have a lot to learn from the way in which they deal with maternal health and reproductive justice.
That's such a great point. I mean, sometimes back to basics is really, because that's where obstetrics was rooted in community initially, right? Like it was the aunties, the moms, the grandmoms that were helping communities birth.
Exactly. How
Yeah.
many of us were born at home, with the doulas, with the aunties, with the grandmas? So yeah, you know, um, and I'm sure that we all have personal examples that we can talk about in terms of what would have worked better for sisters, aunties, cousins, etc. Within this system, if we had taken what was there, what our grandparents, grandmothers, and great grandmothers did in their time.
So true. And that leads really well into our next question in terms of what changes are needed to improve Black women and people's health outcomes, particular in sexual and reproductive health care and holistic wellness.
Want to come back to me, Althea?
Yeah, I'll start with you and then we can open it up to everybody else.
Sure. I think improving Black women's health outcomes requires a transformative change. We often see performative stuff. They tell you that this is going to happen, that's going to happen, and it never happens. But we need to see transformative change at both the systemic level and the community level. And so I think we must begin by confronting the reality of anti-Black racism within the healthcare systems, right? Because often Black women's pain is minimized, ignored, their concerns are dismissed, and their experiences are definitely not taken seriously. So addressing these inequities require, I think, mandatory anti-racism and culturally sensitive, culturally competent training, greater accountability within the health institutions, and ensuring that Black women are represented in decision-making at every level of healthcare policy and delivery. I think we also need to have sustained investment in culturally grounded maternal and reproductive care. That means that expanding access to Black midwives, to doulas, mental health supports, lactation consultants, community-based wellness models that center dignity, trust, and culturally affirming care, which we don't see very often. And given the disproportionately high maternal mortality and morbidity rates experienced by us, the role of Black midwives and doulas is especially critical. They're not simply supports during childbirth. They're there to be advocates throughout the whole process. They are trusted caregivers, they're educators, and often they provide life-saving interventions. And as I said earlier, we all have stories, right? Research and lived experience also consistently show that continuous support from doulas and culturally competent midwives can improve birth outcomes, can reduce trauma, can lower levels of unnecessary interventions, and help counter the bias that Black women too often encounter within medical systems. Investing in all of these traditions of care is not only about improving the services, I think it's also about reclaiming health justice, restoring agency, and rebuilding trust in systems that have historically failed Black communities, in particular Black women. And at the same time, I think improving health outcomes requires us to address the broader self-determinants of health. Black women cannot achieve wellness while facing economic insecurity, unsafe working conditions, precarious employment, inadequate housing, all the things I mentioned before, environmental racism, gender-based violence, unequal access to paid leave and childcare. So health equity is, I think, very, very much connected to labor rights, income security, education, and community safeness. And the last thing I would leave you with is looking at this from a holistic point of view. So holistic wellness means recognizing that Black women's health is not only about surviving systems of harms, but about creating the conditions for us to thrive physically, emotionally, spiritually, and economically. It's about our dignity, right? And so we need to ensure that we have the ability to have self-determination right across our lifespan, and reproduction is included in that.
That was so great. There's so much that I want to pick up on. You talked about social determinants of health. Of course, you talked about midwifery, which of course is near and dear to my heart, and something, of course, that I think can be part of the solution to the Black maternal health crisis. But before I go off on a tangent, I wanted to open it up to our other panelists and see if anyone had anything to add about what changes are needed to improve Black women's health outcomes, particularly in terms of maternal care and holistic wellness.
Maybe I could add a comment. You covered so much, Marie, and it was honestly all of it resonated. I was sitting here quietly thinking, yes, this is it, this, all of that. The only thing that I thought that I could contribute to that or add to that would just be around the role of equity-focused data governance in terms of the ways that in community is brought in as decision makers in the design and interpretation and application of data that is collected. And I think that, without that, we really risk continuing really extractive patterns of without creating meaningful change in terms of what we do with the data that's collected. And I really believe that this is more of an ethical and governance issue about power, community ownership, and ensuring that data is used to materially improve people's lives. And that's something that I think, for myself as someone who spent a long time going into birthing spaces and, after baby sort of care as a labor doula and as a postpartum doula, really seeing how the relationship that people have to the use of their data, their understanding and knowledge about what happens to that and what the pathway is and why and how, whether that translates or not into better outcomes.
Thank you so much for adding that. Dr. Maxwell, do you have something to add?
I would love to. And just building a bit on what Stacia said, particularly around the data, Black women, Black birthing people are at the intersection of race, sex, and gender. And I just want to highlight that in medical literature and scientific literature, most of the data that is collected internationally is generally not focused on women and gender diverse people specifically. Historically, most scientific medical health research was designed by men, for men, about men, and with little, thought towards the differences that sex and gender in particular create when you are designing research, collecting data, reporting research. And then we add on the layer of race. And the experiences of Black people navigating the health system, experiencing health. We're going to be talking more about some of the specifics in reproductive health as this conversation goes on. But suffice it to say that that intersection, I think, has a profound impact on everything we're going to discuss today around sex, gender, and our identities as Black people. And that needs to be really considered carefully as research is designed with the representation of those designing, carrying out the research in collaboration with the community being paid attention to throughout. The other thing I wanted to mention, and this relates back to Marie's comments around, maternal mortality, which I think is one way to assess how well a health system is providing care to its birthing people. We know of mortality rates for Black communities during birth and immediately after birth in most jurisdictions in the world. We know this for most countries in Africa. We know this for virtually all European countries, and we know we can find out or research that number in the United States. So what I'm going to say is going to be a little shocking, I think. We do not know the mortality rate for Black birthing people in Canada. That is not known. And I'm sure we'll have some discussion about why that is and how that's going to change. But I think it's important that we are aware that that number is not known.
So important, and you're right. We'll dive into that a little bit more later, because yeah, we do interesting things in here in Canada in terms of data, and so we'll go down that rabbit hole a little bit. But right now, I'll switch gears a little bit, and I'll move over to you, Dr. Kareen. Your work really challenges traditional focuses on access in reproductive health. And so, what are the risks of continuing to prioritize access without addressing the structural conditions that shape reproductive autonomy?
I'm not going to repeat everything that was already said, but I am going to make a note about data because I wrote an entire paper on it. There's a purpose behind not obtaining racial data relating to reproductive justice and women's right, is to maintain the invisibility lines, is to silence voices. So I think it's important to point focus on the reason behind it. Some will argue that that is not obtained because even if it's obtained, it doesn't really create any systematic changes. But not obtaining the data silences the voices and it maintains status quo. So which side are we going to be on when we're addressing these issues? Data is a reflection of reality in the sense of current time. If we don't obtain data to reflect the current states of certain marginalized communities, we cannot advocate on behalf of these silenced voices because that's how the system functions, is on statistics. That's the point that I wanted to make specifically in terms of data collection. And I want to reiterate that it's done intentionally. It's not done in an obscured way or in a way of being like it's purposely neglectful. That's what it is. Because we have data on a bunch of other things, but we for some reason cannot have racial data when it comes to reproductive justice. I'll leave that alone, and that's only in Canada. In my work, I wrote extensively on reproductive justice in many different facets. The one of the things that I do mention a lot is the sociological components of biopolitics and how the autonomy of the Black woman's body is seen as a form of maintaining testing. It's a way of it's not used, it's not seen as a human way. It's dehumanized. So we see a historical aspect of how Black women's body were used to test. We also see the restrictions that a lot of women were castrated, not being able to have children because they felt that they wanted to control the population. But it's done in a very systematic way. And this was done in Montreal during the 1970s that nobody talks about. A lot of Haitian women who migrated to Canada were advised and were coached and were guided and were manipulated to have a dissect to remove their entire organs to not have any more children because it was better for their health. That still has not been, there's no concrete evidence that that was the case for half of these women that migrated in Montreal during the 1970s. And that's a form of population control. Again, it's a form of reiterating and maintaining status quo. So a system that does not technically provide, a system that provides access to reproductive healthcare can still reproduce inequalities because who's the access for and who's getting the access? Through institutional culture, policy designs, and unequal power relations. A doctor comes into the room and tells you, you should be doing this. You're going to rely on that information as being truth and reality. So for me, reproductive justice, it stands behind the availability of services. It has to include social, economic, racial, and political conditions. that determines whether the individual can genuinely exercise autonomy and agency over their reproductive rights and their lives. When institutions focus narrowly on access without addressing structural conditions, they risk reinforcing the very same systems that were designed to marginalize these communities. So, in the context of choice, becomes conditional rather than autonomy. Structural barriers such as racism, poverty, geographical inequalities, cultural exclusion, and institutional mistrust continues to shape the way reproductive outcomes are provided and the services that are provided to families and women. So what I do basically in all the work that I've done so far is that I challenge the assumptions that institution neutrality automatically reproduces fairness, because that's their approach that they take. That this is approach that we provide with everyone. So this concept of neutrality isn't really neutral, because who developed it, and in what context was it developed, and in what who benefits from these neutral policies. So in many cases, these systems that appear neutral continue to privilege dominant norms while overlooking the realities of those who are most impacted. So reproductive justice, therefore, is not simply a healthcare delivery issue. It's also a governance issue. And if we fail to address these conditions that shape reproductive autonomy, access to risk becomes symbolic and inclusion rather than meaningful equality.
The whole time you were speaking, I was just thinking about this quote, just keeps popping into my head, is that the healthcare system isn't failing Black birthing people by accident. It's functioning exactly how it's designed, right? And so we have to go back. We have to look more upstream at the actual design and start fixing those issues if we actually want to fix the problem. It's so very true. Can I ask, so what would it look like to design reproductive health systems that are built from lived experience rather than retrofitted to include it?
I think Mary Clark Walker addressed it from the core, from the beginning. It takes all of that and more. We need to have people that look like us in these positions that are able to provide these services. And I think the other point that Mary Clark Walker mentioned, I think it was her, that a lot of other countries have these services that are considered less developed. We can easily look at that as a guide and example, as a form of support. But we have this assumption of superiority here in terms of knowledge, not only knowledge, because knowledge is based on who's delivering it, who's determined credible. So keep that in mind, because these knowledge that are being transferable from other underdeveloped countries, and I say this in quotation, are actually more advanced than we are, to be completely transparent. And if we would utilize these and mobilize these knowledge, we would be in a lot better place than we are here right now in Canada. And the fact that we don't have racial data of, and I don't remember who mentioned it, of how many Black women and racialized women have died during childbirth, to me, it's alarming. I would go further and say, what's the purpose of hiding this information when other countries that are considered developed have this data? Because Canada wants to maintain the appearance of being better, and wants to maintain the inclusivity and multicultural. Having these information will go against that image that they're trying to portray. And I make reference to that as polite racism. And this is how I englobe Canada's approach to many, many things that are considered outside of their their sector of mindfulness and thinking. They are politely dismissing and silencing voices. And this is why, look it up, polite racism is exactly a manifestation of how we feel in Canada. Because they don't outright call you the N-word means that we're not racist here. Like, there's plenty different ways of being racist. And one of those ways is by silencing voices, by not having data that is reflective of the current situation that's happening during reproductive justice, childbirth, and many, many other facets beyond childbirth.
Well said. Polite racism. That's a great way to put it. I was trying to think of what the word is, but that really sums it up to what we often experience here, and the way that what we're trying to do and what we're trying to build for our communities isn't resourced because we don't have the data behind it. So you just covered so much that's there. But Marie, did you have something to add?
The other thing that I would add to that is the dismissal of intergenerational trauma. With people saying that it doesn't matter, what happened in the past doesn't matter, but all of that plays a role in, our reproductive justice. When you asked earlier about the connection between labor and reproductive, there is a huge connection. We as a country continue to look at things in silos, and this doesn't affect this. Everything has an impact. You know, when you look at workplace discrimination, it has an impact on pregnancy, it has an impact on motherhood. When you are seeing Black women working in particular types of jobs, doing unsafe work, and in unsafe working conditions while they're pregnant, when there is a lack of paid leave, again, it harms the mother and the child. When they don't take into consideration maternity and pregnancy in terms of occupational health and safety, again, unions, labor also need to be held accountable for looking at these things and including them in collective agreements and as part of what we do as labor activists.
Absolutely. And before we move on, is there anything to add in terms of what would it look like to design reproductive health systems that are built from lived experience rather than retrofitted to include it? Just want to make sure that there's no gems to be dropped before I move along.
I think we covered quite a bit of them. Stacia,
did.
I was just going to add funding. We talked about funding for midwives, funding for doulas, funding for cultural services, providing true universal health care. We talk about in this country that we have universal health care, but we don't, right? Looking at postpartum support. Okay, so we have maternity leave, paternity leave, parental leave, but what supports are there? What supports are there in terms of mental well-being for, you know, during that whole reproduction process? All of those things really need to be looked at for reproductive justice to really have an impact.
You're so right. And it kind of brings back to that when you talk about silos, like our healthcare is the same. It's like, okay, something wrong with your kidney, you go here, you're pregnant, you go here, but it's all interconnected, right? And we really need to kind of address the whole person to be able to give the best care. Stacia, did you have something to add?
Yeah, no, I was just going to thank Dr. Cohen Sanchez for the comments about polite racism and the idea of neutrality as, you know, the baseline, as though that is an actual position that a system can have, because all systems reflect the values and assumptions and priorities. There are policy choices that are made. It is not just, oh, we have this policy, nothing can change, right? Like, so I think that that's an important piece, the important context that you've added to the conversation. I absolutely agree with you about how we don't want to look like we want to overturn multiculturalism or the idea of Canada is better and all of that. But what we see in reality is that it's so much more than about access. It's about all of those pieces that both of you have pulled in around people's whole lives, right? We don't walk into systems as a two-dimensional human being, right? There's so much more to our existence, so much more to our lives than that. So yeah, I just wanted to express gratitude for that.
Dr. Maxwell?
For sure, echoing your comments, Isha. I'm very grateful for all that you have shared with us, Dr. Cohen Sanchez and Marie Clark Walker. I think there are many learnings that the greater public needs to understand our allies, and those who are perhaps not our allies need to understand these issues. And I think even within our communities, we need some more understanding of these really important issues. What I wanted to say around the design of a health system for a reproductive health system for Black communities, how could we do that? What would be the ideal state? So clearly, an engagement with our communities would be an important first step. Part of the community is also those who are providing the care and the healthcare professionals. So, you know, I'm one of the obstetricians in the health system, you know, in the academic and hospital system, one of a few, and hopefully in the future, one of many. And what I have found to be very rewarding is the collaboration across health professionals that we've started to develop. Many of us on this call right now participate together in a number of activities, bringing those of us who are in medicine, whether it's family medicine, obstetrics, gynecology, fertility care, midwifery, doula care, health disciplines. So sometimes we call those our colleagues in allied health, bringing all of those individuals together who share an aspect of common identity and a common devotion to advancing Black reproductive health. I think there's great power in that type of coalition, and we're seeing some of the fruits of that labor working together. We're talking about labor. My mind always goes to labor and delivery, of course, but we're talking about labor in terms of workforce. But I do think that working together, we are starting to see some of the positive benefits of research activities designed for and by Black individuals who have expertise, lived experience, who are scientists, who are community collaborators. And so I do, we're going to talk a lot about the systems of harms, I know, during this discussion, but we're also going to talk about strength, Black excellence, and that connection between community, the health system, academia, as being one of the ways forward.
Absolutely. That collaboration piece, I think, is key. And like you said, it is not just even within like obstetrical care. It's bringing in, and there's just so much that comes together to be able to provide good care to a community. And I've seen kind of more of that happening since 2020. There's kind of a big boom of a lot of Black-led, Black-focused kind of groups getting together and trying to do this work, petering off a little bit. So we really need to keep that momentum, because I really do think it is key to making changes and really improving outcomes. I'll switch gears a little bit and bring it over to you, Stacia, because you've led some really groundbreaking community-based initiatives. So can you tell us, what can mainstream health systems learn from community-led reproductive care models, including midwifery and grassroots approaches?
Thank you. Um, I think that mainstream health systems have the biggest opportunity is really to broaden how we conceptualize care itself. And I think that community-led models often work from that understanding that outcomes are really shaped by not only by their clinical treatment, but also by those broader cultural, relational, sort of structural contexts in which people live. And so the more that we're able to understand the whole person and those contexts, the more we're able to provide more meaningful and effective care and interventions and supports to the people who are using the system. I think that you see that community-led models are often creating stronger experiences, stronger satisfaction levels and outcomes, but really that's because they're grounded in a lot of trust. There's a lot more continuity of care. There's the more capacity to have it be more culturally responsive and have a longer term relationship building time with the communities that are served. So, models like midwifery care, especially expanded scope midwifery care, the doula supports and services that are offered, peer navigators that are showing up within healthcare systems more and more, grassroots reproductive health initiatives are able to really engage more fully in the context of people's lives. And depending on the model, many of them also provide supports that help mitigate some of those stressors we've talked about and those structural inequities that we've been talking about already today. I think that there's a challenge in the fact that we treat those models or these models as supplemental or as optional, rather than recognizing them as essential components of a functioning health system. So we really love to celebrate them rhetorically, but they're often underfunded, have short-term funding, precarious funding. They're expected to fill systemic gaps without really sustained investment over long periods of time, or strong institutional support. So I think that the questions that we need to be asking is really why these models that communities consistently identify as effective are still funded as temporary projects rather than treated as core health infrastructure. So that's really about how willing is our system to redistribute resources, to really legitimize these models as effective and useful for answering our own problems and our own challenges, and really looking at where decision making power lies, and whether or not there's movement ability to shift that.
Absolutely. It's so true. And we sometimes talk about this at such a high level. So I'm going to ask you, do you have an example of some of those programs? And even if it's not like sexual and reproductive health specific, because I think it's important for people to kind of understand and hear, like, what is an example of those programs? We talk about it in theory, but what is working well, and how can we replicate this in other settings?
Mhm. Well, Um, there's many examples. I think that, obviously, one example is your program, Althea. That's a great program. That is one example that I would love to point to, is Ancestral Hands Midwifery. I do feel like, having worked a lot with the expanded scope midwifery models that are out there, I really do see that some of those are great opportunities for collaboration across systems. I find whenever you're bringing community-led, community-based projects to the table, what you're getting is so much more than that project itself and their way of working. What you're getting is the ability to access community organizers and folks who've learned how to make a lot of work happen with different types of resources. It's a very much more flexibility. Another example is, in my time working at Parkdale, I initiated a free breast pump and infant feeding program for low income women, primarily Black clients attending that. And, really looking at, working with our academic partners to sort of say, if we're going to do this, we need to slow down. We need to explain properly to community what we're doing. We need to have a lot of flexibility room. We need time. We need resources. We need to be able to research it so that we can see what is scalable. And so embedding research from the start, and there are a number of community programs that have embedded research from their inception, and what that looks like, so that you can take those models, you can take what works. And I'm very proud to say that actual project, that research partnership, just won the Jennifer Rayner Health Equity for Research Award for 2026. And thank you. And I think that it's important to look for where there are those opportunities to take this to another level and scale it in other places in the country, so that we can see, because we still don't have a coordinated maternal like surveillance system in Canada, right? We have these piecemeal frameworks that are used from region to region, but we don't have something that extends across the whole country, right? So there's work to be done there, in terms of taking what community already knows and has been talking about for a very, very, very long time, and actually applying that to our health systems.
Thank you for that, and for some examples. And now it feels like I was just throwing you a question so you can mention my program, but so thank you for throwing that in there. That wasn't the intention, but I'm glad it worked out that way. But it's so important, and like you said, to not treat these as pilot programs, but to actually resource. I find a lot, as you are building up community work, you're often told why you can't do it. Oh, well, you don't have this in place, or you don't have that in place. And it's like, okay, well, give me this or that so that I can continue to do the good work. If you're saying that I don't have these in place, it's because it's a party of one or two, or there's people that are trying to do this work and build it from the ground up, obviously need that support and that ongoing support.
Can
Dr.
I?
Cohen Sanchez, did you have something to
Yeah,
add?
I like to add something. We need to change the narrative in the on many different things, but on aspects of research that is related to reproductive justice or anything to do, they view it as advocacy work. They don't view it as a change to the system. So until we change that language, and then it's not just a temporary advocacy work because we're advocating for a group, we're advocating for human rights, which is directly linked to specific groups. That is one thing that I've observed within academia specifically. Whenever we address things that are related to groups, they want to translate that into advocacy work. What advocacy works equates temporary. Until we change the language and the narrative, and this is why I say neutrality and approach is essential, and how the lens that we use to examine situation is how we're going to respond to the situation. Until we can, because there's plenty of organizations that deal with reproductive justice. Like Stacey mentioned, there's a bunch of stuff. Just Google. There's a lot of stuff here. Why is it implemented in a way that is the longevity can be further down because it's not respected and it's not viewed as essential and it is not viewed as something that is important for the totality of the Canadian society. It is fragmented into a specific group, and that specific group, unfortunately, is viewed as not human enough to maintain those resources. So if we're gonna have a conversation, let's just be transparent about it and I don't sugarcoat things. People who know me, and I'm in the academic world, the same way I'm in advocacy world, and the same way I'm in social. I don't really care about how things come off because the truth is the truth. This is what it is. These are factual things. And if we can't have hard conversations with the people that are stakeholders, that are advocating these systems, that are advocating and maintaining these systems in place, we're just talking to ourselves here. And this is how to translate this into policy work, and that could actually create some sort of systemic change for our peoples and for everybody who's affected by this. I went off. I know I went off.
I love true speakers. I love true speakers. No, it's important. Sometimes we just need to say the thing, right? And I appreciate that. So thank you very much for saying that. Dr. Maxwell, did you have something to add?
I do. I'd like to build a bit on what Dr. Glenn Sanchez has just said, and also echo back to your question, Althea, about some examples of community-led participatory research where it's working. And one of the things that I've noted in the last few years is the emergence of Black health data that has been designed and collected in collaboration with Black communities, and the prominent role that that many Black scientists, health researchers, and community members are playing in the emergence of Black health data. So I did give that stark statement earlier around our lack of knowledge around what the true rate of Black maternal mortality is, and that is true. We do not have that number. We do have, however, emerging data on, preterm birth in Black birthing people in Canada. And I'm not talking about the United States or the United Kingdom or any other jurisdiction. I'm interested to hear, also what is happening in Canada for people of African descent. Access to fertility, fertility outcomes, the role of fibroids, endometriosis, and gynecologic and reproductive health. In addition to a number of different types of pregnancy issues. So I mentioned preterm birth already, preeclampsia, hypertension, so blood pressure disorders of pregnancy, hemorrhage related to birth and after birth. We have a number of researchers. I'd just like to name a few of them just so people are aware of their names. Professor Josephine Etoa, Professor Priscilla Boakier, Dr. Aisha Lofters, Dr. Crystal Clark in the maternal mental health area, Professor Bukola Salami, Professor Carly Wilson Mitchell. These are a few among many who are active participants and designers in academia who are driving this research and data collection. I do think that the representation of our community members in research is crucial, and I think we've talked a bit about that already. In the medical area, we are seeing still low numbers of Black medical learners. I just want everyone to still be aware that that's an issue, and that maintaining our Black learners or supporting our Black learners through clinical training and beyond is still a challenge. There are attrition rates that are still concerning. And there are many supports and networks now that are in place to support our Black learners in Ontario and in other provinces in Canada, but that continues to be a challenge, and we are looking at systemic solutions to address that. And the other thing I wanted to mention in terms of, success, where are we seeing impact and real change? The Canadian Institutes of Health Research, CIHR, it's our federal research funding institution. They have a sponsored program called the Pan-Canadian Women's Health Initiatives. There are 10 funded hub grants. Two of these focus on reproductive health in particular. And both, and many of us here on this call are probably involved in both of those. And those projects, one on justice and equity in perinatal health, and the other one on what we call near misses in medicine and in reproductive health. Maybe a person doesn't undergo a mortality, but they may have such a life-altering negative health outcome that it has a significant impact on themselves or their child. Those two areas of research have included from inception collaboration with Black community members with lived experience, researchers, clinicians, people like myself. So the landscape is changing. That just wasn't the case 5 to 10 years ago. So we're already seeing that evolution in research design changing specifically to be inclusive from inception of Black people.
Thank you for that. And it really just ties it all together. Like we were talking about it, this is not all separate work happening in silos. It's all connected. Even when Stacia, you're talking about like the underfunding and programs being able to build in research from the start, like partially underfunding doesn't allow you to be able to do those things because it's like that's a big chunk of work. And so it's just a cycle. And like Dr. Kareen, you were talking about, it's systemic of how these programs and these systems are kind of working against our communities. And it's so important for us to all kind of join forces and to make sure that we're working together to kind of move to the best outcomes. And I kind of want to connect this back. Stacia, I'll ask you. So if we're really serious about reproductive justice, what would real accountability look like across health systems and governments, especially in improving outcomes for Black women and people?
Thank you. I think, accountability, I mean, I know that we've all been talking about accountability for a long time. And I think that, if like a lot of these are policy choices, much like other issues that affect our communities, these are choices, and this is about money, and is about power. I think that systems that um, could place accountability measures that require actual change would have to be tied to things like mandated public reporting, and equity indicators that are tied to health outcomes, funding agreements that link equity and performance. Like this is fundamentally about the way that the system is designed. And as you mentioned earlier, both you, Althea, and Dr. Cohen Sanchez, like this is not an accident, right? Like that is a choice that was made. I think that you know we know that the communities most impacted by these things are still excluded from decision making spaces, and so accountability couldn't just mean consultation after decisions or frameworks are already designed. It means like resourcing communities, compensation for expertise and lived experience, and sharing governance and decision making authority in meaningful ways. And I think that when you strip away all of the layers and think about what it would mean to actually share decision making with communities, systems aren't designed for that, nor do they have interest in doing that. I think that one, as a person who works a lot in the policy realm these days, I think that there's one challenge that we have in Canada is that equity is often framed aspirationally rather than operationally. And so we produce excellent, beautiful strategies and commitments and statements of intent, but we have very few enforceable accountability mechanisms that are tied to those outcomes, that the timelines, funding, or even institutional performance. So it's not that we don't know, I know that we know that the inequities exist. I know we need better data that shows that, but communities know, providers know, researchers know. And the issue has a lot to do with institutions and systems that have not been required to change.
that light bulb in my head, yes, have not been required to change. And like you said, tying it to funding is because that's the only thing that seems to be valued. So tying it to funding shows that you're actually valuing it. And that's the only way to actually make the needle move.
And yeah, Dr. Cohen Sanchez said earlier, right? You said that about these is nothing is neutral. These are all based on values, choices, someone sat around in rooms and made those decisions and endorsed it and decided not to endorse other things. It's the same. There's other policy choices and other even income benefits in Canada are decided. That is a decision that a federal government or provincial government makes. We're not going to raise the rate of OW or ODSP this year. We're not going to, like, all of those are choices, right? And so it does tie back a little bit to what you spoke about earlier, Althea, and I think also you, Marie, talked about shifting the public narrative. And until there is that shift, there is not going to be value placed on this issue, right? Like they go hand in hand. And if there is the perception that socially in society we need to make these changes, that money will be found. That's the end of my soapbox chat.
Oh, and I love it. I love it, Marie.
Just gonna say yeah, everything that Dr. Maxwell, Dr. Cohen Sanchez, Stacia has said, you too, Althea, is about ensuring that we are there at all levels, not just when the words are on paper or when they want our input after they've already determined whatever they are determining. But once we get those words on paper, there also needs to be action, right? And some of these things are not complicated. I look at when we go back and I look at labor, right? Paid parental and prenatal leave. That's not difficult to do. Workplace accommodations during pregnancy, not difficult to do. Protection for pregnancy discrimination. A living wage. How far would a living wage go, right? Safe working conditions and accessible, affordable childcare. All of those things tie into reproductive justice. And again, not difficult. They just have to have the will. We talk about political will. They have to have the will to actually do it. And if we know that they're not going to do things for our community, then we need to make sure that we have people in strategic places at all levels to ensure that it gets done.
Absolutely. And that kind of brings us again back to the research piece, which Dr. Maxwell has touched on, and oftentimes funding being related to having data. So, Dr. Maxwell, there's an increasing attention to Black reproductive health research in Canada. What are some of the key research advances being driven by Black reproductive health scientists?
Thank you, Althea. I think I did touch on a few of those items in some of my previous remarks, so I won't repeat those, but perhaps I could add on that we are in need of a national obstetric surveillance system, as Stacia had mentioned, and it is in its pilot phases in Canada. So it's being launched in a couple of provinces to test, how the system would work. It requires collaboration across public health units and hospitals and birthing centers and all different types of health professionals, and so it's complicated but doable because we know that it's been done in other health systems. And what will be unique about the development of our obstetric surveillance system is that pretty much from the beginning, there will be Black voices at the table in the planning and design, the human-centered design, the Black person-centered design of data collection. What birth outcomes, for example, are important to Black people, and that may not be evident to other communities, or may be different in other communities. And so it's more than just what is the rate of postpartum hemorrhage, what is the rate of preterm birth, what is the rate of severe maternal morbidity. It's also about respectful care, culturally competent care, people feeling safe to access the care. So it's universally available, but it's not universally accessible, as we all know, within Canada. And so while it's still in evolution, one of the things that we are learning about is some of the retrospective data. So historically, in different parts of Canada, is it possible for us to go back in time and extrapolate from census data, birth registries, and so on, what has been the experience of Black birthing people and what have been some of those outcomes? We are cautioned when it comes to this discussion in Ontario because we have fairly rough, imprecise ways, I will say, of collecting race-based data on birthing, as many of us on this call will know very well, that at best in our province, we may capture 70% of the racial and ethnic identities of birthing people in the province. And so that data is used to then extrapolate what has happened in the past. And so over the past, for the period of about a decade in the early 2000s, we have now published in collaboration with one of our colleagues, Dr. Modupi Bias, and the Society for the Obstetricians and Gynecologists of Canada, some preliminary data about the 20 Black women who died in childbirth over that period, and what can we glean from the limited information that we have. So when we talk about maternal mortalities, we're interested in understanding what happens to people who die during birth and shortly after birth, but also what happens to the folks who are passing away about a year later, but still within that defined period that we use to describe maternal mortality. And what we're learning about the Black women who died during or shortly after giving birth is that there are a lot of cases related to things like preeclampsia, hypertension, complications of pregnancy, cerebral vascular accidents, so things like stroke, bringing abnormalities that arise in and around pregnancy, and then some other more rare complications. Interestingly, for Black women who die distant from the time that they give birth, we're seeing a number of deaths that are related to cancer. And so it is likely that that cancer was present in and around the time the individual was pregnant, and it eventually led to their demise. And so that makes me think about the monitoring, the screening for chronic illnesses in our communities, particularly around cancer screening. We do have prominent health researchers and community partnerships in Black communities looking at these issues. But things like breast cancer screening, Pap tests, cervical cancer screening, and other areas are so critical to population health, and then, of course, directly impacting maternal health, both in the short term and the long term. So while there's not a lot to report yet, because we don't have the ongoing active sort of prospective data collection that is in progress, we will get there. It's going to take some time. I will say that we do have the representation. I think that will be required to ensure the development of a system that will be appropriate for our communities. I'm an optimistic person, so I believe that to be the case, and I believe that the experts in Canada who should be involved in these projects are being involved. We're definitely being engaged. And so, I am hopeful that we will have that monitoring in place. That data is incredibly important. Not collecting it is a choice, to echo what has been discussed here already. And so in collecting that data, we will have to answer very big questions about what do we do with that data? Who is going to protect that data? How do we ensure that it doesn't harm our communities? And how do we ensure that it helps our communities? But very practical things. We're able to figure out regional clusters of women who are having significant health outcomes or death related to a particular condition that can be actioned. Then we can understand what to look for, how to treat that. It may be that there'll be guidelines and things that will need to be deployed in certain areas. That's what we've seen in other jurisdictions based on trending in maternal mortalities. You identify things like drowning deaths, I guess, and then you discover that it may have been related to eclamptic seizures, and then focus on ensuring people are screened for those conditions in that location and elsewhere. So it can be powerful. Data can be very powerful, and it can be used to advance health. And so the key will be making sure that at decision-making tables, that there will be power sharing to drive those positive outcomes for our communities.
Yeah, I love your optimism, and I'm glad that it feels like we're starting this process from a good place. And because that's where my mind goes is you look at the states and they've, been collecting this data for a long time, but they still have some of the worst outcomes for Black birthing people. And how do we not repeat those mistakes? So it's great. We're asking community to prove something we already know to be true for a lot of things. It's like, okay, we need data to, support funding and all this sort of stuff, but within community, we already know what we're seeing anecdotally. But so once we have that data, how do we then ensure that these actual changes are made? Somebody puts a bomb in their shoe, and all of a sudden we all have to take off our shoes before we go into the airport, but we don't see the swiftness of action when it comes to this data. So I guess I want to open up to everybody in terms of how do we ensure that this gets used to actually make changes? I know, Dr. Maxwell, you've touched on some things, but is there anything else that people have to add in terms of how do we get action from this data that we are now going to be collecting, and hopefully have a lot of emerging data that shows maybe we need something a little bit different from our healthcare system?
Oh, I can start. I do think that the accountability piece is crucial. We do have to move away from sort of the advocacy, the pilot work, the advisory committees, to really having let's say guidelines that derive from our future obstetrical surveillance system be part of the operational plan for health systems, health jurisdictions, for hospitals. It's the only way. If there's no accountability, if it's not mandated in the work that the healthcare system is doing, then it'll be interesting, but it won't change anything. And that's not easy to do. That requires powerful, allies and members of our community being present at those decision-making tables or organizations, in government, in public health, in all of the different offices of government that impact health. So it's not just the health sector; it's transportation, it's labor, it's many of the things that we've talked about here already. And certainly at the healthcare unit and hospital and or birthing center levels, it needs to be present at all levels of our health system. That is no easy feat, and representation and meaningful inclusion continue to be challenging, I think, for Black communities across Canada. But again, the landscape is changing. I think we, as Black health advisors, researchers, scientists, clinicians, are more collaborative and united in the work that we are doing. We have meetings where we're sharing what each other is doing. I'm struck with all the things that are happening in Canada, in the Black health landscape, and I'm just learning about them. And I try to read a lot and be aware and attend a lot of conferences, as I'm sure all of you do. And so just even knowing the scope of work that's happening nationally, I think is important. So a forum like this one to share and exchange is important. There is strength in numbers. Nothing about us without us, I think, is the mantra I always think back to, and that we keep pushing and advancing this work together.
Thank you. That sums it up really well. And, surprisingly, we're already kind of coming towards the end of our time. Time flies when you're having fun and having great discussions with brilliant people. So thank you for being here. But I want to ask one question kind of across the panel. Um, so what is one change, so whether it be policy, practice, or mindset, that would meaningfully advance reproductive justice in the next 5 years? And maybe Dr. Cohen Sanchez, we can start with you.
I'm always fighting for this unmute button. All right. So I think the first thing is how we treat lived experiences. We need to stop treating it as a supplemental rather than fundamental. So too often systems are designed through dominant institutional frameworks. We spoke about that. And then later they attempt to include marginalized voices through the consultation process. That doesn't that's mean that that's counterproductive. So for me, designing a reproductive health system from lived experience would require moving away from performative inclusion towards participatory governance. What that means is that we're involving affected communities not simply as advisors, but as active contributors in shaping policies, designs, implementing the evaluations, and accountability structures from the outset. So lived experiences must be recognized as a legitimate form of expertise, not just something that you went through. Um, and not as a form of antidote. The input and the decision of these lived experiences is foundational in the process. I also think that systems would need to prioritize relational trust, which is not discussed very often, cultural safety, and emotional realities along the sides with the clinical outcomes. Reproductive health care does not only occur outside of broader systems, race, gender, class, migration, disability, historical exclusion. In fact, it's basically asking marginalized communities to adapt to institutional norms. That's really what it is. So institutions themselves must be willing to transform their structures and practices, in which I discussed earlier on. So what I see this as a governance transformation. The challenge is not simply increasing representation, because we got that. But it's fundamentally rethinking, relearning whose knowledge is considered legitimate, which I mentioned earlier, and who's considered credible, whose experiences are centered, and how institutions' power operate within the healthcare system. So what I usually refer to is deconstructing to reconstruct. And I think a lot of people know this proverb, like we can't use the same tools that we used to build the house in order. So we already know that. We need to change completely the way we address what we perceive as inclusion. I have a complex reality and an understanding with what's considered inclusion. And I talk about this in my research. It's very much reflective of parameters. So you're included, but you're included within a certain framework. Your voice can be heard, but it must be heard within a certain tone. It must be heard within a certain narrative. So that's not inclusion. That's me adapting to you what you perceive of me. So until we can have authentic inclusion and people are able to be themselves in these spaces and express their lived realities, it's counterproductive. And I talk about the duplicity of consciousness in one of my papers, because what happens is that I have to alter and accommodate my experience to make sure that I don't ruffle your reality of me. We have to be mindful of all these factors when we talk about inclusion. I won't go into the neuropsychological aspect of it or the social aspect of it, but inclusion to me is a term, it's a buzzword that has been thrown around because I've been in places that's considered inclusive and I did not feel included. Like I did not meet the narrative that the inclusion systems had in place. I went against the inclusion systems, so I was not included. That's the issue. And yeah, I'll leave it as that.
Oh, fantastic. And just so important. Authentic inclusion, relational trust, lived experience is not supplemental, like just all key aspects. Um, what is one change, policy, practice, or mindset that would meaningfully advance reproductive justice, Stacia?
Well, Dr. Sanchez took some of mine because I'm kidding. And I actually also wanted to say thank you for challenging the notion of inclusion because it suggests that someone has to invite you in, and we are not asking to be invited, right? And so, yeah, I appreciate that very much. I think, you know, cross-sectoral quality improvement collaboratives is what comes to mind. Like I feel like one theme that I've noticed throughout a lot of our comments today has been really the way that we can all identify what are the other areas of people's lives that overlap or intersect with reproductive justice, sexual health, and reproductive rights. And it is that those cross-sectoral conversations. It's understanding what we can learn from other places where they have made advancements. It's really about sharing knowledge, sharing resources, and making sure that we get to where we want to go. So that is one thing that came to mind. And the other that came to mind was piloting OHIP covered doula services in hospital settings to try something out that has been tried in other countries.
I love that. Collaboration is key. And let's not just pilot it. Let's just do it.
Yes,
Fun doulas. We
yes.
already
I think
know,
my
right?
brain was thinking about get your foot in the door, but no,
Right. Oh, 100%.
think bigger. You're right. You're right.
Absolutely. Marie, one change that would meaningfully advance reproductive justice.
Not getting the foot in the door, kicking the damn door down. But anyway, moving beyond crisis responses and inequity management towards, and this is right in line with what Dr. Cohen Sanchez and Sasia has talked about already. So moving beyond crisis response and inequity management towards a system grounded in dignity, autonomy, justice, prevention, and holistic wellness, which is all about self-determination. For me, that would make sure or ensure that Black women not only survive childbirth and reproductive health care, but also thrive before, during, and long after. And again, that has to be done in collaboration with what Dr. Cohen Sanchez, Stacia, as well as Dr. Maxwell have already talked about.
Thank you. And Dr. Maxwell, we'll finish with you.
I don't know if I can add much more. Perhaps one thing to consider, one thing that I would like to see, again, around the idea of self-determination in the research realm would be that it is hardwired into the system that no group of scientists or researchers reports on outcomes for Black community without having engaged and co-designed their work, reporting, knowledge translation, knowledge mobilization closely and and collaboratively with Black community members, lived experience Black researchers. We're all part of the Black community and should be at the table from the get-go. And so journals would also only publish work that had clear evidence and demonstration that of that thoughtfulness and of that process from beginning to end.
This has been such a pleasure, folks. Amazing conversation. I know some of you, it was great getting to know a couple other of you through this discussion, but such amazing, brilliant people sharing great information with our community. So thank you to our panelists for sharing your insights, expertise, and leadership. Today's conversation really reminds us that reproductive justice is not just a single issue. It's deeply connected to race, economics, labor, policy, power, all of those things. So moving forward requires not just awareness, but accountability and sustained action. So thank you all for being part of this conversation on Mother's Day. It's an important day to have this conversation. So thank you all for being here. Thank you to everyone for watching and wishing you a happy Mother's Day. Thank you.
Look how far come on your own, but never alone. Through the rain and through the shine, here's your moment, it's your time. You stood tall and now you see, standing in your destiny. 100 woman growing strong. 100 woman